Clostridia, as a family, are obligate anaerobes, meaning that oxygen is toxic to them. In nature, they thrive in deep, compact soil, and when they feel the stress of fresh, oxygenated air, they often produce spores, which are metabolically inert and extremely resilient to the environment. Then, when the environmental conditions improve, the spores are able to sprout into fully fledged Clostridia. When doing a gram stain, Clostridium botulinum stains purple, or gram-positive, and it's a bacillus, meaning that it looks like a big cylinder or rod under the microscope. Clostridium botulinum is notorious for producing a toxin, called botulinum toxin, which causes botulism. Historically, to preserve foods, processes like sausage making and canning became popular. Unfortunately, these environments block out air. If a Clostridium botulinum spore gets in during the food preparation process, it can grow and produce botulinum toxin, contaminating the food. In fact, this is how Clostridium botulinum gets its name, since botulus means sausage in Latin. When it infects a can, the can begins to bulge with air, because the bacteria has metabolized sugars into short-chain fatty acids that form a gas. And although the short-chain fatty acids are mostly made up of carbon dioxide and hydrogen, the gas is particularly foul-smelling. Now, nerves that use the neurotransmitter acetylcholine are those we use for muscle control. Upon ingesting a contaminated food product, botulinum toxin works by binding specifically to these nerves, inhibiting muscle contraction. The toxin comes in 8 distinct types, named A, B, C, D, E, F, G, and H, and they vary in their toxicity. The neuron takes in the botulinum toxin by endocytosis, creating a small vesicle that floats within the neuron's cytoplasm. The toxin then activates and slips out of the vesicle and starts to cleave snare proteins. Snare proteins tug vesicles containing acetylcholine to the plasma membrane, where they get released into the synapse and transmit a signal to the muscle. Without snare proteins, acetylcholine doesn't get released, so no signal is sent out by the affected nerves. The result is that the muscle gets completely relaxed and flaccid. Muscle weakness usually starts in the muscles supplied by the 12 cranial nerves, so the muscles that control the face, eye movements, chewing, and swallowing. In addition, nerves of the autonomic nervous system that rely on acetylcholine are also affected. Early on, botulism can cause a bulbar palsy, or impairment of cranial nerves 9, 10, 11, and 12, and over time, there may be a descending paralysis. Symptoms of botulism include double vision, drooping of the eyelids, an inability to make any facial expressions, and difficulty swallowing. In addition, because of the autonomic nervous system effects, it can cause dry mouth, postural hypotension, or low blood pressure while standing, nausea, vomiting, and constipation. Often, the symptoms of botulism can progress to complete flaccid paralysis, which can be deadly if it involves the respiratory muscles. The diagnosis of botulism is primarily based on a serum analysis for the botulinum toxin. Growing Clostridium botulinum in culture is rarely successful because anaerobes are difficult to grow in a lab setting. Treatment of botulism is mostly supportive, and the goal is to assist the affected patient in breathing. In adults, botulism can also be treated by passive immunization with an antitoxin. 2 types of antitoxin exist: a trivalent one, which covers toxins A, B, and E, and a heptavalent one covering toxins A, B, C, D, E, F, and G. The purpose of antitoxin is to catch the free toxin molecules in the bloodstream before they can damage the neuronal proteins. Now, most canning processes undergo high-pressure cooking, which is like autoclaving, and reliably destroys the toxin and sterilizes the contents of the can. Other preserved foods can be conserved by high acidity or low pH, for example, pickles. The most common form of food-related botulism is infant botulism, or floppy baby syndrome. Newborns and infants still have poorly developed gut flora, and their gut is vulnerable to colonization by Clostridium botulinum. Colonizing bacteria will continue to produce their toxins directly in the intestine, causing botulism. Honey has been implicated as a potential vector for transmitting Clostridium botulinum spores and should be avoided in children under 12 months. Finally, 2 types of botulinum toxin, A and B, are less toxic and can reliably induce long-lasting neuromuscular junction block, so they are sometimes diluted and injected into a rigid muscle to relax it. Other diseases that can be improved with botulinum toxin are hyperhidrosis, or excessive sweating, achalasia, and focal dystonia, which is when there's an involuntary spasticity in a muscle group. Botulinum toxin is also used as Botox in aesthetic surgery to help smooth out wrinkles for a few months. Alright, as a quick recap, Clostridium botulinum is an obligate anaerobe that makes spores and secretes a botulinum toxin, which causes botulism. Spores are usually found in badly preserved food and honey. Consumption of food contaminated with botulinum toxin can lead to neuromuscular block and flaccid paralysis that may be lethal through suffocation without supportive treatment.
Clostridium difficile is difficult to treat, hence the name. Clostridia, as a family, are obligate anaerobes, meaning they don't require oxygen to thrive. In fact, they're better off without it. In nature, they thrive in deep, compact soil, and when they feel the stress of fresh, oxygenated air, they often produce spores, which are extremely resilient to the environment. When conditions improve, the spores can sprout into fully fledged Clostridia. In the lab, when doing a gram stain, Clostridium difficile is gram-positive, or purple, and look like big cylinders or rods. Now, Clostridium difficile can sometimes establish residence in our colon, typically after a person has accidentally ingested the bacteria that originally were living in another person's colon. This is called the fecal-oral route, and it usually results from eating with unwashed hands. In fact, around 5% of the population are asymptomatic carriers of Clostridium difficile, but the vast majority of these individuals don't seem to have an issue with it. That's because there are a number of bacterial species living in the intestines that make up the microbiome. These various bacterial species, called the normal flora, coexist in an environment where they live together and compete for resources. A healthy normal flora, therefore, doesn't allow Clostridium difficile to dominate the intestines. However, if the diversity of that normal flora is disturbed, by antibiotics for instance, then organisms that are resistant to antibiotics, like Clostridium difficile, can thrive while other bacteria might die out. That can allow for overgrowth of Clostridium difficile. Another way to disturb the equilibrium of the gut biome is use of chemotherapy or prolonged use of elemental diet, which is gastric feeding tube of elemental liquid nutrients, often seen in intensive care units. In these situations, once again, the normal flora gets disturbed, and it tilts the equilibrium towards Clostridium difficile. Combinations of high antibiotic usage and parenteral feeding make Clostridium difficile a common problem in intensive care units and nursing homes. Now, in infants, it turns out that many have Clostridium difficile without having the disease. So it's unclear if colonized infants need to be treated for Clostridium difficile at all. Now, Clostridium difficile's main pathogenic mechanism is the production of various toxins, which it uses to help establish itself within the intestines, primarily within the colon. The first is Clostridium difficile toxin A, or TCDA, which is a highly potent enterotoxin that destroys the cytoskeleton within an intestinal cell. This causes the intestinal cell to undergo apoptosis, or programmed cell death. If enough of the intestinal cells die, the tight junctions between neighboring cells fall apart. The damaged intestinal tissue begins to get porous or leaky, and that causes a strong inflammatory response from the immune system. Neutrophils begin to infiltrate the intestines, and they're greeted by an additional toxin called Clostridium difficile toxin B, or TCDB, which is a cytotoxin. TCDB enters cells, including neutrophils, and causes cellular apoptosis. The combined effect of the two toxins leads to pseudomembranous colitis. On a colonoscopy, the result of the inflammatory response is the formation of elevated, yellowish-white plaques called pseudomembranes, which are filled with pus. Symptoms of Clostridium difficile infection most commonly include diarrhea with or without mucus and blood, abdominal pain, and a high fever. If left untreated, the infection can lead to a toxic megacolon, which is where the colon gets very dilated to the point of rupture. If there's an intestinal rupture or perforation, it can lead to septic shock and even death. Diagnosis is usually confirmed by stool testing for the presence of C. difficile toxins. This is done by enzyme-linked immunoabsorbent assay, or ELISA. An individual with an active infection will usually test positive for Clostridium difficile toxins A and B. Colonoscopy or sigmoidoscopy can be used to confirm the diagnosis by visualizing the pseudomembranous appearance. Now, because antibiotics can cause Clostridium difficile to take hold, it's important to discontinue any offending antibiotics as soon as possible. Having said that, the treatment of Clostridium difficile infection is, you guessed it, antibiotics that are specifically effective against Clostridium difficile, like metronidazole, which is used in mild to moderate disease, and vancomycin, which is usually reserved for severe disease. These antibiotics are usually taken orally, so that they function primarily within the gut. Individuals are also given oral rehydration therapy to help with the diarrhea. It's important to avoid using medications that slow the course of diarrhea, like loperamide, because that can worsen the disease. If antibiotics aren't effective, an alternative treatment for prolonged and recurrent C. difficile infections is a fecal transplant. The idea is pretty solid. Basically, it starts with obtaining a feces sample from a healthy donor, usually a family member, which contains a sample of a fully balanced intestinal flora. The fecal sample is given to an individual with C. difficile either by a nasogastric tube or by an enema, and once the fecal transplant is done, the healthy flora begin to compete with C. difficile, reducing its numbers and toxin production. Along the same lines, probiotics containing organisms like Lactobacillus and Saccharomyces boulardii yeast are used to help prevent and supplement the treatment of pseudomembranous colitis. Now, like most things, prevention is better than a cure, and healthcare facilities work hard to isolate individuals with Clostridium difficile infection so that it doesn't spread to others. Healthcare providers typically use contact precautions like gowns and gloves, as well as cleaning their hands with soap and water rather than hand sanitizers to help avoid spreading the highly resistant spores from one person to another. Surfaces are cleaned with cleaning agents like a mix of 1 part sodium hypochlorite or household bleach to 10 parts water. This is then used to clean surfaces and objects like elevator buttons, light switches, taps, and the toilet area. Alright, as a quick recap, Clostridium difficile is a sporulating, gram-positive obligate anaerobe. When the microbiome is altered by changes like the use of antibiotics, the bacteria becomes dominant and secretes toxins A and B, which cause intestinal damage. The overgrowth of Clostridium difficile leads to pseudomembranous colitis, which results in diarrhea with or without mucus and blood, abdominal pain, and a high fever. Treatment options include antibiotics or fecal transplant, whose goal is to reestablish the normal flora and to keep the growth of C. difficile in check. In healthcare settings, it's important to isolate affected individuals, use contact precautions, wash hands with soap and water, and wipe down surfaces with sporicidal cleaning agents. Clostridium perfringens is from the family of Clostridia, and as a family, they're obligate anaerobes, meaning they don't require oxygen to thrive. In fact, they're better off without it. Anaerobes, Clostridia included, tend to lack the enzymes catalase, or superoxide dismutase, so oxygen is actually toxic to them. In nature, they thrive in deep, compact soil, and when they feel the stress of fresh, oxygenated air, they often produce spores, which are extremely resilient to the environment and can even survive cooking. When conditions improve, for example when food is slowly cooled and stored, the spores can sprout into full-fledged Clostridia. In fact, at an optimum temperature, Clostridium perfringens has one of the fastest growing rates of any bacterium. In the lab, when doing a gram stain, Clostridium perfringens is gram-positive, or purple when gram-stained, and look like big cylinders or rods, called bacilli. Clostridium perfringens is a common cause of food poisoning. In fact, it's sometimes called the cafeteria germ. That's because it typically infects food that's been prepared in large quantities and then kept warm for prolonged periods, such as in cafeterias or buffets. Clostridium perfringens are found out in the environment, and they can accidentally contaminate food when it's been left out for a while. If a person eats food contaminating with C. perfringens, the bacteria will soon colonize the gut. Within 24 hours, the bacteria starts to make Clostridium perfringens enterotoxin, or CPE. The CPE specifically targets the tight junctions that connect epithelial cells lining the intestines to one another. When the tight junctions get destroyed, it causes inflammation and compromises the structural integrity of the intestinal wall. Fortunately, CPE is heat labile, so prolonged cooking at 72 degrees Celsius or above will inactivate it. And that's one reason why freshly cooked food is best to eat. The other reason is that it's simply tastier that way. But uncooked foods, like salads, or reheated food, like leftovers, can be a good home to Clostridium perfringens. The symptoms of Clostridium perfringens enteritis include abdominal cramping, watery diarrhea, and vomiting. Fortunately, most of these improve over the course of a day, as the bacteria make their way through the intestines. In terms of treatment, antibiotics aren't needed, and instead the goal is to keep the individual well hydrated. Now, instead of getting into food, Clostridium perfringens can also sometimes get into a wound. This can happen when wounds are made by dirty, sharp objects that come into contact with soil that's rich with Clostridium perfringens and other anaerobes, like gardening or farming equipment. And if there's a deep wound, it can cause clostridial myonecrosis. That's where another toxin, Clostridium perfringens alpha toxin, or CPAT, causes direct damage to cells, causing them to swell up in lyse, or pop. The result is rapid, massive destruction of muscular and soft tissues, eventually resulting in tissue death or gangrene. Symptoms of myonecrosis are extreme pain and swelling, and sometimes thin, watery pus can leak out of the wound. Occasionally, there's so much tissue damage that blood vessels can break and create blood-filled bullae on the skin above gangrenous tissue. A classic sign is crepitus, which is a sound of crackles as you press down around the wound. It feels like gas moving around in the tissue, which is why myonecrosis is sometimes called gas gangrene. The fast-moving infection and massive tissue destruction can lead to fever and tachycardia, and can even progress to hypotension, shock, and eventually death within just a few hours. Clostridial myonecrosis can be hard to diagnose early on, because it can look like cellulitis. And since untreated gas gangrene can spread rapidly, the diagnosis is usually made based on the severity of the infection and how quickly it spreads. Having said that, the diagnosis can be confirmed with an anaerobic tissue culture, but that usually takes a few days, which is far too long for individuals with gas gangrene. Treatment of Clostridial myonecrosis requires prompt and complete surgical excision of the necrotic tissue. This can sometimes include amputation of an infected extremity. Individuals typically need supportive care to help manage fluids and help maintain their hemodynamic status. High-dose antibiotic treatment with penicillin V or clindamycin is also needed to kill the bacteria. Sometimes additional broad-spectrum antibiotics are used as well, especially in really ill-appearing individuals, in case there's a co-infection. Sometimes hyperbaric oxygen is used. That's where a person is placed in a hyperbaric chamber which contains 100% oxygen, because that amount of oxygen is deadly to Clostridium perfringens and other anaerobes. Alright, as a quick recap, Clostridium perfringens is a gram-positive, spore-forming, obligate anaerobe that resides in the soil. If it comes into contact with our food, it can cause food poisoning through toxin production. Clostridium perfringens food poisoning typically causes mild symptoms, lasts about a day, and resolves without antibiotics. If Clostridium perfringens gets into an open wound, it can cause clostridial myonecrosis, or gas gangrene, which can be deadly within hours without surgical excision of the necrotic tissue, along with penicillin B and, in some cases, hyperbaric therapy.
Tetanus means being taught, which is a good description of the disease caused by bacteria called Clostridium tetani. Clostridia, as a family, are obligate anaerobes, meaning that oxygen is toxic to them. In nature, they thrive in deep, compact soil, and when they feel the stress of fresh oxygenated air, they often produce spores, which are metabolically inert and extremely resilient to the environment. Then, when environmental conditions improve, the spores are able to sprout into fully fledged Clostridia. When doing a gram stain, Clostridium tetani stains purple, or gram-positive, and it's a bacillus, meaning that it looks like a big cylinder or rod under the microscope. Clostridium tetani is notorious for one of its toxins, called tetanospasmin, which can severely disrupt the neuromuscular system of mammals. Tetanospasmin works by entering special inhibitory neurons called Renshaw cells. Once they get inside, tetanospasmin cleaves snare proteins, which are proteins that pull vesicles that are loaded with neurotransmitters to the neuron membrane. When the snare proteins are cleaved, it prevents the release of inhibitory neurotransmitters, like glycine and GABA. You can think of snare proteins as the rails, and the vesicles as trains that are loaded with neurotransmitters. The tetanospasmin destroys the rails so that the trains can't move. The role of Renshaw cells and inhibitory neurotransmitters is to fine-tune the action of the alpha motor neuron, which is in charge of sending the actual signal for contraction to the muscle. In tetanus, Renshaw cells fail to work, and the alpha motor neuron keeps firing without any inhibitory control, causing muscle rigidity and spasm. Spores of Clostridium tetani are most often introduced into the body through penetrating trauma, like a puncture wound. Puncture wounds are usually anaerobic and warm, and are therefore optimal for growth of Clostridium tetani. And an important point is that Clostridium spores can get introduced from dirty wounds, like a rusty nail, as well as clean wounds, like a recently washed kitchen knife. In fact, any kind of puncture wound or cut brings along the risk of tetanus. Tetanus usually starts with a delayed onset, about a week to a month after the initial injury. In the most common form of tetanus, called generalized tetanus, the spasms begin in the face muscles, most notably the lower jaw, and from there, the spasms spread throughout the body. The spasms are sudden, powerful, long-lasting, and very painful contractions of muscles. These contractions are so powerful that they can result in muscle tears or bone fractures. The classical tetanic triad of symptoms involves trismus, or lockjaw, which are mild to severe spasms of the lower jaw, rhesus sardinicus, or Sardinian grin, which is an abnormal-looking, sustained grin caused by facial muscle spasm, and opisthotonus, which is a severe spasm of all muscles in the body simultaneously, resulting in a high arched back and patient resting on his heels and the back of his head. Tetanus only affects skeletal muscle, so smooth muscle and cardiac muscle continue to function normally. Other symptoms of tetanus involve sympathetic overactivity, which causes drooling, excessive sweating, fever, difficulty swallowing, breathing problems, and irregular urination and defecation. Rarer forms of the disease include the local tetanus, where a persistent spasm will be only localized around the area of the injury. This condition persists for a few months, but will gradually subside, with less than 1% mortality. Even rarer is the cephalic tetanus, which is limited to the muscle supplied by the 12 cranial nerves only. This can happen in the case of head trauma, such as skull fractures, eye injuries, middle ear infections, and sometimes even from tooth extractions. Cephalic tetanus is more likely than other types to cause death. There's also neonatal tetanus, which happens to newborns of mothers that have not been immunized against tetanus themselves. If the umbilical cord is cut by a non-sterile instrument, the newborn can develop highly lethal neonatal tetanus. Newborns of immunized mothers are protected through passive immunity, and hygiene standards have been improved even in the developing world, so the umbilical cords are usually cut with sterile equipment. The diagnosis of tetanus is based on the clinical appearance. One clinical test is called the spatula test, and it involves touching the posterior pharyngeal wall with a wooden spatula and observing the effect. A positive test results in involuntary contraction of the jaw, or biting down hard on the spatula, due to the lower threshold for muscle spasm in patients with tetanus. A negative test result would be a normal gag reflex. Tetanus toxin can also be found in the serum using a bioassay. Finally, culturing Clostridium tetani is very difficult because anaerobes are notoriously difficult and slow to grow. Tetanus is usually treated with tetanus immune globulin, or TIG, which is an antitoxin that binds to circulating tetanospasmin. In addition, muscle relaxants, pain medication, and other supportive care measures are taken while the immune system clears the infection. Full recovery can take a few months of intensive care, as the body's neurons slowly heal. Fortunately, tetanus infection can be prevented with the tetanus toxoid vaccine. Vaccination generates active immunity by injecting weakened or dead versions of the disease agent into the body. Tetanus vaccines in childhood and adolescence are given in the form of a triple vaccine that covers diphtheria, tetanus, and pertussis in a single jab. Alright, as a quick recap, Clostridium tetani is a sporulating, gram-positive bacillus anaerobe that makes the toxin tetanospasmin, which causes tetanus by disrupting the release of inhibitory neurotransmitters from Renshaw cells. Tetanus comes in 4 clinical types: generalized, local, cephalic, and neonatal. Tetanus is characterized by powerful, violent muscle spasms, summed up by trismus, or lockjaw, rhesus sardonicus, a persistent grin, and opus thotinus, a highly arched back with patient resting on his head and heels. Treatment of tetanus involves application of tetanus immune globulin and supportive care measures. Finally, tetanus vaccine immunization can prevent the disease.